Hello, everybody. I'm not sure if everybody here on YouTube is following me on Instagram or on Facebook. But however, I made an announcement that I was going to have a live tonight about documentation tips for breast cancer. Got a lot of little notes and stuff here. So we'll be talking about documentation tips for breast cancer. So come on in. Let's learn more about documentation tips, coding tips. The thing about it is, we can only code what the physician or the clinicians document. We can only code it. We can't put specific codes if it's not in the documentation. However, we can assist physicians with improving their documentation so they can be more specific and we can catch more specific codes. So that's what we'll talk about today: breast cancer neoplasm codes. So I'll start from the root of things. Of course, you have to know medical terminology, anatomy, physiology, things like that. A lot of times to understand clinical documentation or medical records or medical charts and things like that. So neoplasm is simply new growth of tissue that serves no purpose or no physiological function at all. That's what neoplasm is: tissue growth that really serves no purpose. So that tissue growth, that neoplasm can be benign, which is non-cancerous, or it can be malignant. Benign is it only grows in one place. If someone say they has a benign tumor, or you might hear them say they have a malignant tumor. So if they have a benign tumor, benign means only grows in one place, uh, does not spread, and usually typically doesn't recur. Malignant, on the other hand, is it grows, it spreads from one part of your body to another, and it can typically recur. So that's the difference. If you hear the word metastatic cancer, metastatic simply mean, or metastatic neoplasm, or metastatic anything. Metastatic simply means that it spread from one place to the other. You might see the documentation says metastatic liver cancer. That means that the cancer has spread from somewhere else and it's in the liver. So let's talk about this breast cancer documentation. So, and not just in, a lot of my videos are about risk adjustment, of course, but as you know, I have my CPC as well. So this is not a video that's geared specifically toward risk adjustment. This is coding general when it comes to neoplasm, specifically breast cancer. So here are a few physician tips. So since most of the viewers here are coders, so let me give you the tips that you should be looking for, that the physician or the clinician provider should be documenting in their medical record so you can capture all of the specific codes that you need to capture. And of course, the more specific you are with codes, the more reimbursement. So again, we're talking about breast cancer, neoplasm. So let's start with documentation tips for physicians. And I know we're generally all coders here. And the reason I want to start with documentation tips for physicians is because we're reading the documentation from the clinicians. So this will give you a general idea of what you should be looking for in the documentation that'll help you code it to the highest specificity or help you have the appropriate code that you should. So breast cancer, primary and secondary. Document whether the current breast cancer is primary or secondary or in situ. Also document laterality, left or right. Is it left? Is it in the left breast? Is it in the right breast? So you might run across a document or a medical record that says breast cancer. So your job as the coder is to say or query the provider, is it in the left breast? Is it in the right breast? And then, of course, we all know coding is about the highest specificity. So not only can we ask the laterality, is it in the left breast or the right breast? With breast cancer, and we'll get more into it as I provide more documentation and coding tips. But you can also get more specific in breast cancer, and you want to ask, is it in the upper quadrant or the lower quadrant? Is it medial or is it lateral? So it's a lot of in depth when it comes to coding breast cancer. So, like I said, document whether the current breast cancer is primary or secondary. So you're also going to document the laterality. You want to look into that chart and make sure the physician has said whether it's left breast cancer or right. So you also want to see that it's documented that the specific site of primary cancer, including the location within the breast, whether it's the nipple, the upper outer quadrant, the central portion, or etc. So you do want the specific site documented as well. Also, if there is a secondary site, you want them to document specifically the secondary type. So let's talk about current and historical when it comes to breast cancer. So I like to say that coders and okay, so let me give you an example. So I really love Latina countries and I'm saying just Hispanic culture, things like that. So, but there's a different dialect if you live in the Latin country of South America versus living in Mexico or different places. They're all generally culturally the same, but it's different dialect to the same language. Just like if I live in Tennessee and someone else lives in New York, we all speak English, but it's a different dialect and we say different words, but sometimes they can mean the same thing. And sometimes they can mean different things depending on where we're from and what language we're understanding. So that's the same thing between coders and physicians or coders and providers. I'm so used to saying physician because I do physician education. But of course, we know nurse practitioners, also physician assistants also are included under providers. So I always say physicians, not to exclude those. So again, coders and providers, we speak the same language, but sometimes it means a different thing. And let me give you an example. So let's talk about the next segment. We're going to talk about current breast cancer versus historical breast cancer. Is your breast cancer active or do you have history of breast cancer? So there's different times where you're going to use an active breast cancer code, and then there's times when you're going to use a history of breast cancer. Those two codes mean different things. So generally, when physicians or providers say, oh, this patient has a history of this, they're typically saying in their mind, oh, these are the things that the patient has. These are the problems that's wrong with this patient. But as coders, when you say, oh, this patient has a history of, we're thinking, oh, it's history. It's gone. It's no longer being treated. It's not active. It's not here anymore. So they'll say history of to explain what's going on currently. But in our mind, in our books where we're taught in the guidelines, when you say history of, that means it's eradicated, it's gone, it's eliminated, it's no longer being treated, things of that nature. So let's talk about current versus historical. So for physicians, again, this is under the physician tips. Pretty much we're not physicians, we're coders. So I'm just teaching you what you should look for in your physician documentation. And this is going to help you with documentation improvement as well. So we all know that CDI, clinical documentation improvement, a lot of those jobs started around $70,000 minimum. You can look it up. CDI, clinical documentation improvement. So there is a job within coding called CDI, if you didn't know. So that's basically looking through the documentation and making sure that the documentation supports whatever diagnosis codes that are used. So if you see these diagnosis codes, then I need to see inside the documentation some that support this being used. So that's what CDI is, or clinical documentation improvement. So let's get back to what you should look for in your physician or your provider documentation when it comes to current versus historical breast cancer. So do not use the phrase history of to describe current primary breast cancer. In diagnosis coding, history of means the condition is historical and no longer exists as a current problem. In the final impression or the assessment and plan of the medical record, do not document a simple statement of breast cancer to describe a historical primary breast cancer that was previously excised or eradicated. If there is no active treatment, no evidence of disease or recurrence, in this scenario, it's appropriate to document history of. So just to break that down simple, if the patient is not on any active treatment, any chemotherapy, any radiation, oral medicines, none of that. If the cancer has been eradicated or eliminated, whether it's excised or cut out, shrunk through radiation or whatever it is, if there's no active treatment, the patient is on no medication, nothing, then that's when you will use the history of breast cancer code. But if they're on active meds, if they're going to chemotherapy, even if the doctor documents, oh, this patient has a history of breast cancer, they're currently going to chemo. No, if you would tell them to change their documentation because it's a contradiction. You're saying the patient has a history of breast cancer, but they're doing chemotherapy. No, history means it's no longer there. So you would tell them to change their documentation to reflect that it's active. So again, you're going to code history of breast cancer when it's no longer active, no more medications or anything like that. So also for the treatment plan, remember we're talking about documentation tips for physicians. So as a coder, I'm teaching you or assisting you what you should be looking for in the documentation if a provider is documenting breast cancer. So for their treatment plan, they have an assessment and plan, the A&P, where it tells what you're going to do. They're assessing it and they're planning for the treatment. So in their plan, it should document a clear and concise plan of care. It should be clearly documented and stated some kind of plan of care. So it should also clearly indicate whether there's current therapy, whether it's chemotherapy, radiation, whatever it is, clearly indicate whether current therapy represents active treatment of the breast cancer or just surveillance because you had history and you're trying to make sure it's not reoccurring. Clearly indicate whether it's active treatments or whether you're just looking and surveilling the patient to make sure it doesn't come back. Also document when adjuvant therapy is used, whether it's for curative care, palliative care, or preventative care. They need to document that. They need to document whether it's curative care, palliative care, or preventative care. And if you do not know those definitions, of course, curative care means you're giving them this to cure them. So palliative care means you're giving them care to relieve them of their symptoms or reduce their suffering. And preventative care, of course, to keep the breast cancer from reoccurring or coming back. Okay. So also, the physician needs to document if referrals are made or consultations requested, indicate to whom or where the referral is made or from whom consultation advice is requested. So if they've set up referrals for oncology or referrals for anything else for chemotherapy or whatever kind, make sure that's also in the treatment plan. Any kind of referrals or consultation request or anything, make sure that's in the treatment plan. And also Make sure that the physician documents when the patient is to be seen again. So let's talk about adjuvant therapy for breast cancer. So adjuvant therapy is additional treatment given after the primary treatment has been completed. And that's to destroy any remaining cancer cells that might be undetectable, or it could be to lower the risk that the cancer will come back. Give me just a second. So of course, I'm mommy, so I have to check, make sure everything's cool. So again, adjuvant therapy for breast cancer. Adjuvant therapy that's additional treatment. That's additional treatment given after the primary treatment has been completed. And you usually get that kind of treatment to, like I said, to destroy any remaining cells that might be undetectable, and also to lower the risk of the cancer reoccurring. So that therapy also may include, like I said, chemotherapy, radiation therapy, hormone therapy, targeted therapy, or biological therapy. So popular breast cancer drugs, that's good to know. Also, tamoxifen, TAMOXIFEN, tamoxifen. I see that a lot on a lot of the medical charts. What's another one I see? Femara, FEMARA. I see that a lot as well. So also familiarize yourself with different kind of oral medications for breast cancer, also with therapy as well. So let's get to the tips for coders. Now, we talked about documentation tips for providers or physicians and things like that, what they should have in a chart. So let's talk about ICD-10 tips and resources for coders. So we know that breast cancer is going to come out of the category of C50. So your C category is your neoplasm. So C50 is going to be your breast cancer category. And I also want you to know, a lot of people don't know, and some people do, but there are distinguishing codes between male breast cancer and female breast cancer. So men do get breast cancer as well. So there is a different code. There is a different code for men with breast cancer. Great. Somebody said they just created a long prescription spreadsheet for her support. That's good too, to kind of know drugs and things like that, especially if you want to get into CDI, clinical documentation, because a lot of those drugs and medication do support the diagnosis, sometimes. So, and they help you pull out the information you need out of those charts. So someone also asked, she said, what's the requirements for the CDI? Look up CCDS, Certified Clinical Documentation Specialist. Look up that. And then AHEMA has a CDIP, and they'll let you know the requirements. So I don't want to go off into the requirements because the video is about breast cancer and neoplasm, but I will tell you where to go for a resource. Look at AHEMA for the CDIP, and also look for the CCDS, Certified Clinical Documentation Specialist. So now let's get into tips for ICD-10 tips for resources for coders. So of course, the category is C50 for malignant neoplasm of the breast. Now, all of this category includes connective tissue of the breast, Paget's disease of the breast, Paget's disease of the nipple. So excludes one. So a lot of times people they've been coding for a while, and they still don't understand the difference between excludes 1 and excludes 2. So I want to stop here and just give a quick lesson of what excludes 1 and what excludes 2 mean. So if you have your books, if you're on live, of course, this is not a video you playing back, so you can grab your books if you want to. You're welcome. You're welcome, Miss Richardson. So let me explain the difference between excludes one and excludes two so you can understand before you even move further. So I like to give this example because this is a great example to give you a great understanding of what excludes one and excludes two really is. So if you're with me, go to your books, M21, M is in Mary, 21, like you're 21 years old, like you're legal, real legal. So M21, this is one of the best examples that I can have. So I'm looking inside of my 2021 book right now. My 2022 book is packed up. Got to go on a trip this weekend, so I've already put it inside of my bag because I have my first session for my CRC class. I hope you guys joining this live was able to sign up for the CRC certification class so you can get that done. So let's go to M21. So let me go back and explain to you what excludes one and excludes two is. So M21, this code says other acquired deformity of limbs. M21, other acquired deformities of limbs. So under the excludes one, there is a code of Q65 through Q66, Q68 through Q74. And those codes are congenital deformities of limbs. So excludes one. Let me break it down. Let me tell you. So a lot of people try to make it so hard. Let me break it down. Excludes one, excludes two. What does it mean? Excludes one mean you cannot code the codes that's within the exclude one. You cannot code it with the primary code. So, for example, we're looking at M21, like I said, other deformities of your limbs. So that means I'm looking under excludes one, and I see the code Q65 through, Q74, and it says congenital deformities of your limbs. So that's basically telling me I cannot code those codes together. I cannot code other acquired deformities of your limbs with congenital deformities of your limbs. I cannot code those together. So excludes one means these codes do not go together. They won't be billed. They will be denied. They won't be approved. You can't even put these codes together on the claim and make it make sense together. So let me tell you why. This is where your medical terminology and things come in. So I know acquired means that you got this along the way. You acquired this disease. You acquired this condition. You acquired whatever it is. Best example is AIDS, acquired immune deficiency syndrome. You acquired it from someone. You acquired this immune deficiency syndrome from somebody else. So acquired means you got it from somebody. You got it along the way. You hadn't always had it. So if we know our terminology, then we know congenital means you were born with this. So if you see a medical record and it says patient has a 75-year-old patient has congenital heart failure. He was born with the heart failure. Congenital means you were, when you came out your mama's womb, you had whatever disease there was. If they say congenital deformities, congenital heart failure, congenital liver failure, that means you were born with this disease. So again, M21 is other acquired deformities of your limbs, and it's telling me under excludes one that I cannot code congenital deformities of your limbs. This is why. If you put those two codes on the claim, you're contradicting yourself. Either they acquired it along the deformities of their limbs along the way, or they were born with the deformity. Which one? But it's not both. So that's what excludes one means. You cannot code those codes together. And simply excludes two, you can code it together. So pay attention. Everything you need is in your coding book, the instructions, the additional codes that you will need. You really have to pay attention to your code book, and it will guide you to the correct answer. So if the question asks, congenital deformities of the limb, blah, 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 and they have those two codes together. If you look in your book and if you read it like you should or like you know it to be, then you can look at that answer on the question like, oh, I know this answer is wrong because you cannot code these two codes together. Because in my book right here on page 806, this code is under the excludes one, and I can't code it with that primary code. So that's what excludes one mean and excludes two. So a lot of people are coding for a long time and they do not know what excludes one and two is. I wanted to tell you. So also coding the breast cancer site. That is super imperative, coding the site. Always code breast cancer with the highest level of specificity. Carefully review the medical record documentation, noting that the particular site of cancer within the breast is important to code and note for. So now sometimes physicians and other healthcare providers describe the site of breast as position on the clock. So you might see a medical chart that says patient has malignant neoplasm at 3 o'clock. So you will look at it like the breast as a clock, as this will be 12 o'clock, this will be 3, this will be 6, this will be 9. 12, 3, 6, 9. Like a clock. So if you see in the medical record, because some old school doctors, I do see that a lot of old school doctors still use the clock term to, they won't say the upper outer quadrant or the upper inner quadrant. They'll say the 9 o'clock or something like that. So if you ever see that on a medical record, that's how you determine it, like a clock, a clock. You will look at it like that. So malignant neoplasm also is different from your right and your left breast. So for example, in your right breast, this will be the upper inner quadrant, and this will be the upper outer quadrant on your left. Upper inner, upper outer. So let's see what other notes I have for you that are super important. Okay. So, in conclusion, code breast cancer is current or active if the medical record clearly documents active treatment and or it is responsive to the treatment. If the current treatment plan is observation only, or what they may say is watchful waiting. It's like they're watching to see what the neoplasm is going to do. Code it as current then if you see watchful waiting. And also, if a patient has been diagnosed with breast cancer but refused treatment, also coded as active as well. For some reason, some coders think when they refuse the treatment that you don't code it as active anymore, but just because they refuse any treatment that's been suggested doesn't mean that the cancer goes away. Yes, I told you Optum has one of the best training. Told you. So coding breast cancer is historical. And like I said, the active breast cancer codes are going to come from C50 category. Also understand there are different codes for male breast cancer, female breast cancer, 2 different codes. So if you see a man with breast cancer, different code. Understand it's different code. So coding breast cancer is historical. Z85.3 is history, personal history of breast cancer. So you're going to use this code after breast cancer has been excised or eradicated, and there is no active treatment directed toward the breast cancer, and there is no evidence of disease or reoccurrence. You're going to use a history of. Also, if someone is coming in for an encounter for a follow-up exam after treatment for the malignant neoplasm has been completed, use the code from Z08 category also, because this code includes the medical surveillance following the completed treatment, like if it was monitoring for reoccurrence and things like that. So I hope this was a helpful video for everybody of when to code active breast cancer, when to code history of breast cancer, and what to look for in your provider documentation. Also, again, like I was telling you, CDI jobs, usually the ones I see start at about $70,000. CDI is clinical documentation improvement. Most of the time, companies like to hire CDI nurses, which are nurse coders, or nurses that specifically have mastered the documentation portion. And they also hire coders as well, especially if you had it CCDS or the CDIP certification for documentation. So thank you so much for joining me. If you have not liked the video, go ahead and like the video. If you have not subscribed to the channel, please subscribe to the channel. And thank you so much for stopping through. First class for the April CRC is this weekend. It's April the 16th through June the 25th. So in just as short as 11 weeks, people will be getting finishing up their CRC preparation course, scheduling their exams, and passing their tests and becoming CRC certified. So the next class is also going to be in August. Look out for that. So I am also going to do an online self-paced CPC course as well, and hopefully that'll be rolling out this fall. So the CRC course is self-paced. However, although it's self-paced, I don't want to throw anybody in the water and say, hey, it's self-paced. Go ahead and do it. So I've set up live sessions to go over everything to make sure everybody understands each chapter. So a lot of times people, just like I see now, are wondering, can they set up tutoring sessions with me, consultation sessions with career development? As you know, I have a lot of connections with recruiters, jobs. As you look, you see in my email, they're always emailing me talking about a job, and things like this. So if you do want a consultation with me, you want any tutoring or have any questions or anything like that, you can always email me. Now, I will get back with you within 24 hours of the email, but please understand, I got a job, I got a business, I got a kid in college, I got a kindergartner, things like this. So I will get back with you within 24 hours. So if you're looking for consultations, tutoring, CPC, CRC, medical terminology, things like that, or if you have any coding questions. And this is another thing. Even if you don't take the coding course from me, and if you just decided you want to take a coding course, something I thought I was missing. So if you want to take a coding course and you don't want to take my course or anything, but you have questions, I want to make sure everybody have the absolute best information that they could have, or all of the right information in order to make an informed decision. Because sometimes people take these coding classes and it's not the certification that jobs are looking for. And then now you've wasted your time, your money, you've taken a class and nobody's checking for you or that certification that you have. So keep in mind, even if you're not taking a class from me and you want to make sure this is the right certification class, or if I have a question about this, I don't mind. I'm not going to have the attitude, oh, you're not taking a class from me? I don't have any answers. I don't mind answering any questions. My goal is to make sure everybody have, everybody has the right information that they need to make an informed decision about their next career steps if it involves coding. So if you want to schedule consultation, tutoring, anything like that, you can reach me via email at Allied Health Prep Academy at gmail.com. So that's ALLIED, Allied Health, HEALTH, Prep, PREP, Academy, ACADEMY, at gmail.com. Allied Health Prep Academy at gmail.com, and I'll answer all of your questions. So before I leave the live, does anybody else have any questions or anything that I can answer for you before I leave the live? So I guess not. Okay, thank you so much, everybody, for joining me, and I'll see you on next time. Don't forget to like, comment, and subscribe. Oh, if you're not already on my Instagram, the coding coach _CPC, find me there. Facebook, the coding coach, how to get medical coding jobs, and also Dynamic Medical Billing and Coding Group. You can find me on those platforms. Thank you so much. Again, if you have any questions or anything, Allied Health Prep Academy at gmail.com. This is the coding coach. I'm signing off. Y'all have a great night.